You have to start with tooth position. Maybe that's the correct tooth position. Maybe we need to add 6 or 7 millimeters to his anterior teeth and open his bite. That would look something like this on mounted models. But maybe, in fact, we don't need to do that. Maybe we need to crown lengthen the facial of those teeth and only add a couple of millimeters. Totally different treatment plan. Challenging aesthetic and functional relationships. And really the 4 classes of patients, we're going to talk about deep overbite patients that don't have any tooth wear, but they have a deep overbite and they don't like the way their teeth look. We're going to be talking about deep overbite patients that actually have severe wear. We're going to be talking about anterior open bite patients that may or may not have posterior wear. And we're going to be talking about patients that have end-to-end occlusions and may have severe anterior wear, but they also may have severe wear on all of their teeth. But they have no overbite or overjet. And so they're very challenging to restore the anterior teeth, which is what the patient wants.
My name is Ali. I'm the founder of Course Karma. It's our mission to help dentists to find the best CE so that we can provide the best care for our patients. And that's why we partner with great organizations like Spear Education, because we want you to get a little deeper look into what these organizations have to offer and how they can impact your dental career and also impact the work that you do on your patients as well. So we have Dr. Frank Spear. He really doesn't need too much of an introduction. He's globally renowned for his expertise in aesthetic and restorative dentistry. He has a list of awards that I just do not have time to go into because I know Dr. Spear has a really full presentation. But among his accolades was he won an award from the AACD for enhancing cosmetic dentistry in the United States, which I think is just sums up what his career has been. So with that, I'm going to let Dr. Spear take over here. And I'm gonna hide my video. If you need anything, you let me know, Dr. Spear. Thanks again.
Great, thank you, Ali, and thank you to Course Karma for hosting this. Thank you all for coming to visit, and I hope you have a good learning experience for roughly the next hour and 50 minutes or so. What we're going to be talking about is something that's, I think, really important for most clinicians. And that is the patients that live in your practice, and we all have them, the patients that live in our practice that we don't know what to do with. They actually need treatment, but we're not sure how to approach treatment. And so the tendency is that they don't get treated. And when we're not confident about talking to the patient, then we tend to talk to them about, well, this tooth needs this tooth needs that, because we don't have a way of looking at the global picture of who the patient is. So what I want to do is take 4 very specific patients and 4 very specific types of patients. And I want to give you a very systematic way of looking at them that you can apply to any patient in your practice. And it really will give you a different way to see these people and understand what's possible for them. So with that, I am going to share my screen and we will get started. So what we're going to be talking about are specifically patients that have what I would describe as challenging aesthetic and functional relationships. And really the 4 classes of patients, we're going to talk about deep overbite patients that don't have any tooth wear, but they have a deep overbite and they don't like the way their teeth look. We're going to be talking about deep overbite patients that actually have severe wear. We're going to be talking about anterior open bite patients that may or may not have posterior wear. And we're going to be talking about patients that have end-to-end occlusions and may have severe anterior wear, but they also may have severe wear on all of their teeth. But they have no overbite or overjet. And so they're very challenging to restore the anterior teeth, which is what the patient wants. I couldn't do this presentation without my colleagues that I've been with most of my career. Unfortunately, Vince Kokich Sr., great orthodontist, passed away 10 years ago this July. But Dave Matthews, periodontist, Vince Kokich, orthodontist, and myself spent 30 plus years working on these patients that you're about to see. And we were fortunate. We passed that on to the next generation. So Vince Kokich Jr. took over Vince's practice. Greg Kinzer joined me in 1998, when Greg and I are still together. Jin Janukiewski took over Dave Matthews' practice. And the six of us are going to all have had some hand in every case that you're going to see in this next hour and a half. So where do we start? Well, the tendency for most dentists is they want to make study models. So you get some study models and you're sitting looking at the study models and you realize that you still don't know what to do. So you take the study models to some friends of yours and you say, hey, look at this case. What do you think I should do? And they go, I don't know. Why don't you mount the models? And you think, wow, well, okay. So you pull out an articulator and a Facebook and all these things and you mount the models. And you realize you still don't know what to do. And so what I'm going to suggest to you is that mounted models and study models aren't going to help you with the treatment plan initially. They will help you with the second part of the treatment plan. They won't help you with the first part. And the reason's really simple. When you see wear on teeth, there's really two ways to think about tooth wear. What I'll describe as segmental wear, where some teeth are worn, but other teeth have no wear at all. So an example would be somebody who has significant wear on their anterior teeth and no wear on their posterior teeth. The challenge is, as those anterior teeth wear, they don't sit there like that. You don't see an open bite. Instead, those anterior teeth erupt. And now you look at it and your brain thinks, I got to open the bite. I got to treat the whole patient. This is like a full mouth rehab. No, it's not. It's an anterior tooth position problem. It's not a vertical dimension problem. One of the first things I always look at when somebody hands me some models that have wear on the anterior teeth is I look at the posterior teeth. If the posterior teeth aren't worn, it's not a vertical dimension problem. It's an anterior tooth position problem. Now, there are patients that have generalized wear. You get wear on all the teeth. Those people definitely have the opportunity to lose vertical dimension. But those teeth can also erupt some as well. And so if we go back to this patient that I was saying, so where do we start? Where we start is we have to figure out where to put the teeth. And that's going to be the theme for every single patient I show you today, is you have to start with tooth position. Maybe that's the correct tooth position. Maybe we need to add 6 or 7 millimeters to his anterior teeth and open his bite. That would look something like this on mounted models. But maybe, in fact, we don't need to do that. Maybe we need to crown lengthen the facial of those teeth and only add a couple millimeters. Totally different treatment plan. And what do we need? We need the face. We need to have the face. That's his full smile. Here's his lip at rest. He's minus 7 millimeters of tooth display at rest. Normal will be somewhere between 1 and 5. His lip moves reasonably well, but his teeth are way too short. And so what was the actual treatment plan? It was the first one. It was open his bite, in this case, almost 7 millimeters. And it was a full mouth because of the wear on all the teeth. But it was the face that dictated where the teeth went. Back in 1986, I came up with what I called facially generated treatment planning. It was basically focusing on the fact that you have to treat the maxillary tooth position first. Prior to that, people treated the occlusion first. Everything when I was in school in the 1970s was all about the occlusion, all about focusing on getting the occlusion to meet some goals. Wasn't at all about tooth position or aesthetics. What facially generated treatment planning basically says is you have to treatment plan from the outside in. You have to start with the face. Let the face tell you where the maxillary teeth should go. Once you've established where the maxillary teeth should go, now you can deal with the occlusion. Okay? And today, it's not just even aesthetics that determines where teeth go. It's the biology around airway as well, because now we're much more in tune with people's breathing and our goals for their airway. So basically, facially generated treatment planning consists of 4 steps: aesthetics, function, structure, and biology. Aesthetics is tooth position, tissue levels, and where the maxilla lives relative to the patient's skeletal base. Function is all about occlusion. It's joints, muscles, and how the teeth fit. Structure is how you restore teeth or replace teeth. And biology is really endo, perio, oral surgery. We may treat from the bottom up. In other words, there's patients that we may need to treat some of the biologic issues first. But when we treatment plan, we always treatment plan from the top down. We always treatment plan tooth position, gingival levels first. Now, what about things like joint conditions and airway? Well, in reality, we have to know about those things because they do affect tooth position and they affect the relationship of the maxilla to the mandible. And so prior to just definitive treatment planning, if your patient has airway issues, you need to understand, is it a soft tissue problem or is it a skeletal dental problem? Because that will affect what we do in the treatment planning. What if the patient has temporomandibular joint issues? Same thing. Is it something that's going to impact how you put the mandible relative to the maxilla, or is it not? There's a lot of patients that have joint issues that are noisy, but they don't really impact our treatment negatively. And what if the patient has deep caries? We have to take care of that first. What if they have infections? We have to take care of that first. So prior to, quote, the facially generated treatment planning process, you have to deal with acute issues. You have to deal with infection. You have to deal with pain. You have to deal with deep caries. And you have to have done some sort of assessment. It doesn't mean a sleep study, but you have to have done some sort of questionnaire that at least identifies whether the patient may have airway issues. And at Spear, we don't think about airway as a sleep apneic problem. We think about airway as a 24-hour-a-day, 7-day-a-week problem. And so our treatment plans are formulated to give a patient the ability to breathe through their nose 24 hours a day, 7 days a week. We're not in the market of just placing an appliance to get rid of the sleep apnea at night. Okay, but you have to know about airway because airway is going to impact the relationship of the maxilla to the mandible in some patients. Okay, and specifically, you really have, if you have a patient that has airway considerations, we typically think of expanding our treatment plans, expanding arches, expanding to make room for tongues in particular, rather than old-fashioned school of like orthodontics, for example, might be to take out teeth and retract. These days, we tend to not think in those terms. Instead, we think about, can we expand? And then just like with airway, we have to know how to evaluate joints. Now, in the hour and 20 minutes or whatever we have right now, there's no way I can go into detail on any of those topics, but I want you to be aware, yes, we have to have evaluated those things before we start into our aesthetics, function, structure, biology discussion. So what are our goals? Because if we're going to be treatment planning, we have to have some goals we're aiming at. And really our goals are biologic, and that's airway. We want the patient to be able to breathe through their nose 24 hours a day, 7 days a week. That means the palate has to be wide enough and the maxilla has to be forward enough for the tongue to live in the palate. If the tongue doesn't fit in the palate, the patient's going to be mouth breathing. And if they grow up as a mouth breather, they're going to have a really constricted arch, and they're not going to get the kind of sleep that you want them to have. We want a pleasing smile aesthetically for our outcome, and we want a functional occlusion for our outcome. So those are our goals. Now, I'm going to walk you through what I look at as sort of the parameters when I'm treatment planning. And what I'm going to tell you is I'm going to look at basically what is average. And when we look at research about things like how much tooth shows at rest when the lips are at rest, how much does the lip move in a full smile? Most research is going to report the middle of the bell curve. And so that patient that you're looking at on the right is in her 20s. And for someone in their 20s to show about 3.5 millimeters of central at rest and to have the high lip line go right up to the gingiva, that's the middle of the bell curve. That's a typical 25 to 30-year-old. But the reality is we may not always hit that target. So we have to understand most people are going to fit a little bigger range than that. And so what I think of typically is how much tooth display at rest, typically 1 to 5 millimeters. And I'd like to keep the gingival display in a full smile under about 3 millimeters. Research shows that lay people tend to not notice gingival display if it's under 3 millimeters. But we're also going to see that we have outliers. Some people are way off the chart. He's 28. He is minus 5 millimeters of tooth display at rest. At age 28, he can't show his teeth, nothing, in his full smile. She is 60. She shows a nice 3 millimeters, 3.5 millimeters of central at rest, but her lip moves 14 millimeters. She's off the charts in terms of lip mobility. And so I'm going to give you some numbers that I'm going to use in treatment planning, but in reality, there isn't a correct number. There's just a range, and that range has to be applied to each patient. So the numbers I would give you in terms of tooth display at rest, and how do we get this picture? It's really simple. You ask the patient to say Emma, not M, Emma. If you just ask them to say M, they'll close. You have to have them say Emma. And when they open with their lip at rest, you take the photo. What's the range I'm trying to shoot at usually? 1 to 5 millimeters, as I said, of central incisor display at rest. Okay. Now, what influences that? The position of the teeth in an AP relationship. So if the teeth are more prominent, the lip is going to move up. If the teeth are more retracted, the lip is going to go down. Lip mobility. Lip mobility refers to how far the lip moves from its resting position to its highest position. Normal lip mobility runs around 5 to 9 millimeters. And again, it's influenced by where are the teeth? How prominent are the teeth? Okay. Incisal plane, occlusal plane, you're all familiar with smile lines. Once we get the centrals where we want them, we basically want to make sure the laterals, the canines, and the premolars and the molars all form a nice occlusal plane that tends to follow the patient's lower lip. Inclination of the central incisors, orthodontists typically do that off cephalometrics. I don't take cephalometric radiographs. What I do to judge inclination is I draw a line along the occlusal plane and I draw a line parallel to the labial surface of the central. It's really easy to do on a photograph on a computer. And then you can simply measure the angle formed between the two. 85 degrees is a really nicely inclined central. If you end up less than 80, that tooth's probably too proclined and needs to be brought back. If you end up greater than 90, that tooth is retroclined and needs to be brought forward. So again, these are just the targets we're going to be shooting at, because the patients I'm going to be showing you, they don't match any of this. They all have problems with tooth position. Okay. Gingival levels, we typically want the two centrals even with each other, and then we drop down to the laterals. Research would tell you it doesn't matter if it's a 0.5 millimeter drop, a millimeter drop, 1.5 millimeter drop. As long as the two laterals are the same tissue heights, people don't notice. And then usually it goes back up to the cuspids, which are close to the same plane as the centrals. What we want typically in terms of, and you're going to see we use gingiva. Once we have identified where we put incisal edges, we use gingiva to adjust the width to length ratio of the teeth. What's the range we're shooting for? 75 to 85%. If I get a width to length ratio somewhere in the 75 to 85% range, that's a pretty pleasing central. How long is a normal central? 10.5 to 11.5 millimeters. These centrals are 11. So I'm just quickly going through, this is sort of the goals of where we're headed. But as I said, the people you're going to be seeing that I'm going to walk you through, they don't have these goals. So we're going to have to use these to help us plan their treatment. Papilla levels, the first thing we want to see with papilla levels is we want from central to lateral to canine on each side symmetrical. So all the papilla are in the same plane. And then kind of in an ideal world, the papilla between the centrals will live 5 to 6 millimeters from the incisal edge. And especially in patients that have tooth wear, that becomes an issue, because as teeth wear and erupt, that distance from the incisal edge to the papilla gets shorter and shorter and shorter. And so oftentimes in wear cases, you actually have to reposition not just gingival margins, you have to reposition papillas as well. And then finally, once you get the maxillary tooth position and tissue levels and papilla levels sort of sorted out, then you start thinking about occlusion. And as I said, in the time we have today, there's no way to do a deep dive into occlusion. What I'm looking for in terms of my occlusal relationships is in the patient's intercuspal position when they bite. I want simultaneous contacts on all the teeth. I want them to typically have enough overbite so that when they move left, move right, move forward, the overbite separates the posterior teeth. If we look at bite force and you ask somebody to clench as hard as they can on central incisors, they'll put about 20, 25 pounds on their centrals. You move to the premolars, they'll put about 100 to 125 pounds on their premolars. You move to first and second molars, they'll put 200 to 225 pounds on their first and second molars. So we want to use the anterior teeth for guidance to separate the posterior teeth when the mandible's moving, because the anterior teeth receive so much less force. And so typically the overbite's going to be, let's call it 3 millimeters plus or minus a little. Again, there's no set number, but the key is overbite requires overjet. Overjet is what actually controls the amount of overbite. When we have a patient with excess overjet, we end up with a deep overbite. When we have a patient that has inadequate overjet, we end up with almost no overbite. So a lot of what you end up finding in treatment planning is you're managing overjet to be able to get the functional relationship you want. And the eruption that creates the overbite also has a huge impact aesthetically. If you have very little edge, or if you have an edge-to-edge bite with no overbite, you probably have some under-erupted anterior teeth. If you have a deep overbite because of excess overjet, you probably have excess tooth and tissue display. Right? So that's why orthodontists love a class 1 molar relationship. You've got the mesial buccal cusp and the buccal groove of the lower molar. If they're not missing any teeth, that gives you just the right amount of overjet. So when the anterior teeth erupt, you get your 3 millimeters plus or minus of overbite. All right. Now, where do I actually start treatment planning? I actually start with 4 pictures of the patient's face. Not on every patient, obviously, but when you're talking about these complex patients that you're not sure what to do with, you need adequate documentation, and you need the facial pictures to evaluate the patient's skeletal growth. Because if they have a skeletal growth problem, it's probably not going to be corrected by dentistry. It's most likely going to be corrected by surgery. So we're going to have a frontal view with the patient's face at rest. We're going to have a frontal view full smile. We're going to have a profile view, lips at rest. And we're going to have a profile view full smile. So that's where I start. Now, let me walk you through what I'm looking for in each of those pictures. So the first thing I look at is I measure from glabella, right between your eyebrows, to subnasale, the base of your nose, to menton, the base of your chin. And what we know is that in normal vertical facial development, typically that mid-face will be 45 to 50% of the total, and the lower third of the face will be 50 to 55% of the total. We then evaluate the patient's facial profile. Same exact thing, except now we go glabella, subnasale, and pagonian, which is the most prominent part of the chin. So there's glabella again, there's subnasale, and there's pagonian. And now we draw a line between those and we measure the angle formed by those 2 lines. And normal facial profile, a class 1 facial profile, will be 165 to 175 degrees. She's right in the normal range, 170. So I don't want to spend a ton of time on this, but it's helpful for you to see patients who have some skeletal problems So I'm going to walk you through two examples real quick that have vertical problems. So she has a very short lower face. She has a very long lower face. So the one on the left, if we do our measurements, she actually comes in significantly short. We do our measurements on the one on the right, the lower face comes in very long. So 56, remember the mid face should be 45 to 50%. The lower should be 50 to 55%. Her lower third of her face is very short compared to her mid face. This one's just the opposite, 42 to 58. Now, what's that do? When you have a short lower face, you typically have inadequate tooth display and you have a deep overbite. When you have a long lower face, you typically have excessive tooth and tissue display and you have a tendency towards an open bite. And in reality, there are genetic issues at play as to why these people look the way they do, but there also can be some growth and development issues. So what really affects the vertical dimension of the face a lot is the ramus length. So from condyle to angle of the mandible, we have patients that have normal ramuses, we have patients that have long ramuses, we have patients that have short ramuses. And what happens is when you have a normal length ramus, you get a normal mandibular plane angle, normal tooth display, normal overbite, normal overjet. When you have a long ramus, you get a very flat mandibular plane, you get decreased tooth display, you tend to have a deep overbite. When you have a very short ramus, you tend to get a very steep mandibular plane angle, excessive tooth display, excessive gingival display, and a tendency towards an open bite. And so now if we go back to these patients, you can see really long ramus, really flat mandibular plane angle, very square face. You're not going to help her look better, honestly, with dentistry. It's a skeletal problem. You could make the teeth look a little bit better, but you're not going to be able to do what really needs to be done. And so if we look at her Ceph, we can again see that long ramus, flat mandibular plane angle. And what she really needs is the maxilla brought down. The problem is if you do that, the masseter and medial pterygoid just want to put the maxilla right back up. So if a surgeon simply down fractures the maxilla, there tends to be a lot of relapse. So instead, what the surgeons typically do is they end up doing double jaw surgery. They take the maxilla and they tip it down in the front, but leave the molars where they are. And then they take the mandible and they tip it down in the front. And now we go from before surgery to after, and now she has normal facial proportions. Now her lower face is actually a little longer than her mid face. And the big difference is nothing was done to her teeth. Look at the change in tooth display because of correcting the skeletal problem. If we go to our long face patient, it's exactly the opposite. Long, narrow face, short ramus, steep mandibular plane angle. And in her, what you want to do is intrude the maxilla, which actually is a doable surgery, and it has a relatively low relapse rate. And sometimes you actually have to do the mandible as well. But in her case, the maxilla is going to be impacted 5 millimeters. And then the mandible is going to be rotated up into occlusion. And you go from the left screen to the right screen. There's nothing you and I could do with dentistry that's ever going to achieve those goals. Not going to happen because it's a skeletal issue. Okay, the other thing you need to look at, and this has a lot of importance with airway, is something called Andrews line. Andrews was an orthodontist who did a ton of research on this as to where should the maxilla and maxillary anterior teeth be in an 8 anterior posterior direction. And what he discovered is that the patient has normal head posture, so they're just looking off at the horizon. And you draw a line from glabella. The ideal central incisor position is right even with that line. So her Andrews line, her central incisor facial surfaces are right where they're supposed to be. Okay. We also want to talk about something else related to airway, and it's called interlabial gap. And interlabial gap, the easy way of thinking about it is if the patient's lips are at rest, okay, so there's her upper lip at rest, that's where her lower lip is at rest. The interlabial gap is the space between the lips. And the key to the interlabial gap is for them to breathe through their nose, the patient has to be able to bring their lips together without strain. Another way to say it is, if they close, the lip should hit first before the teeth. If the teeth hit first when they close, now they're going to have to strain their lips to bring their lips together. And that tends to make people want to mouth breathe. And so these two photos are sized identically. So if we look at her upper lip length, we can see when she's at rest or when she closes, her lips stay the same length. So she has a correct interlabial gap. And as I said, the easy way to think about it is if when the patient closes, the teeth hit before the lips close, that tends to lead to mouth breathing. All right. So again, just so you can see skeletal problems, here's our 28-year-old. You go ahead and you do his profile, and what do you notice? Whoa, it should be 165 to 175. He's 186. He's very deficient in the maxilla. His Andrews line, if you were to draw his Andrews line, the labial part of his lip is where his central incisors should be. There's no way anybody's going to do anything to make this guy look better just doing dentistry. This is a skeletal base problem. And so what was done? He's class 3. He's going to have his maxilla advanced. Here it is following the advancement. He went from -5 millimeters of tooth display at rest to +3. And he went from showing no tooth when he smiled to showing the full central. Okay. So that's why we start with the facial photographs. Now, most of the patients I'm going to be showing you actually don't have skeletal problems. But I wanted to touch on showing you patients that do have skeletal problems so that you recognize how to evaluate these photographs. Because if you discover that your patient has a skeletal issue, it's probably going to end up really needing to be treated by the orthodontist and the surgeon if you want a great result. And then last thing we'll look at related to airway issues again is interpalatal molar width. How far apart are the molars? You measure it at the gingival margin. You don't measure it at the cuspid because teeth can be tipped in or out. So we measure it at the gingival margin. It's very easy to do on a model, but you can do it in the mouth as well. What are we looking for? We're looking for a normal interpalatal molar width of between 37 and 39 millimeters. If it's less than 31, Jim McNamara, who's a very well-known orthodontist, his research said if it's less than 31, that patient's not going to be able to breathe normally. They're going to need their maxilla expanded. And so you've got the width of the maxilla, which is determined by measuring interpalatal molar width, and you've got the projection of the maxilla, which is Andrews line. Okay. And typically, in most people, if you measure from tip of canine to tip of canine, that will be equal to the interpalatal molar width or just slightly less. All right, so just again, to show you an example of a patient treated who has interpalatal molar width problems. She has very narrow buccal corridors. You can see the darkness in the posterior. She happens to be a dentist. She has undergone a sleep study, and the sleep study, she'd done it twice. Both times came out totally normal. She's seen 2 oral surgeons. Both of them want to expand her palate. She doesn't want that. And from her position is she breathes fine. She just doesn't like the aesthetics. And you can see the crossbite. The crossbite extends all the way from second premolar clear back, well, actually first premolar even, all the way to second molar. So what she is willing to do is she's willing to do orthodontics, but she's not willing to do the surgery. And so since she doesn't have an airway issue, what we're going to do is we're going to have the orthodontist do as much expansion as they can. But in all honesty, we're not going to get a lot. And then I'm going to use restorative dentistry because she needs a ton of dentistry on her posterior teeth. I'm going to use restorative dentistry to make it look like her arch is much wider than it is. So her arch is 31.6, her interpalatal molar width 31.6. She's definitely narrow. Okay. Her canine to canine distance is 34.5, which is much more normal. So here she is post-ortho. The orthodontist did a really nice job of lining up the teeth, but they can only expand the posterior so much without doing some form of bone grafting. And so since she's not going to do the maxillary surgery to expand, and I think I mentioned it, she's in her 60s, the orthodontist did everything they could, but it's still narrow. And so, yep, this is one that I'm just going to fake it. And so I'm going to go through this with you as we treat these patients. Is the treatment plan that I'm showing you what I would call airway favorable? It expands the room for the tongue. Is it airway neutral? It really doesn't change anything. Or is it airway unfavorable? It actually constricts the space for the tongue. I'll call this one airway neutral because we're not changing anything. We're just changing how it looks. So there's the diagnostic wax up, jumping the crossbite by bringing the buccal surfaces out on the upper, rolling the buccal surfaces in on the lower. And there she is before and after treatment. And now when you look at the smile, yes, she's definitely much fuller. Didn't improve any airway issues, but her airway wasn't a problem for her. If she would have had airway issues, I strongly would have recommended that she have the maxillary surgery to expand her palate. All right, so now we're going to start jumping into the patients that I mentioned earlier. The deep overbite patients, the edge-to-edge patients, all of those kinds of folks. So we're going to start with people that have end-to-end occlusions. And the first thing you need to realize is if somebody has an end-to-end occlusion, it's an overjet problem. They don't have enough overjet. Now, they may not have enough overjet because there's a skeletal problem. Could be they're missing some teeth in the upper arch, so the upper arch is short. Could be the upper teeth are retroclined. Could be that they've had a lot of wear and the teeth have erupted, because when teeth erupt, we lose overjet. Could be that they've postured their mandible forward. And if we actually put them into a seated condylar position, typically called centric relation, sometimes maybe we do get enough overjet. Okay, so our patient here, he fractured his anterior teeth when he was 12 years old. He went over the handlebars on a bicycle. He wants to look better. And he's molar class 1, and he has almost no shift from a seated condylar position forward. So we're not going to get any overjet by seating his condyles. And his posterior teeth have no wear on them. His posterior teeth are like perfect. The teeth that need to be treated are those 4 incisors. And that's a really easy treatment plan, except he's had an end-to-end occlusion. And so the end-to-end occlusion, the only way you could add length to the incisors would be if you opened his vertical. But if you get overjet, you don't need to open his vertical, because overjet will create the room for you to then add to the incisors and get normal overbite. Okay, so there's our problem. No overjet. So now let's go through our process. Let's assess his tooth position, his skeletal development, and let's see if we can figure out why he looks this way. Where did this come from? So there is his lip at rest. He's showing a millimeter. But we know we're going to add length to the teeth anyway because they're too short. But yeah, he's showing at least, bottom line is the millimeter is better than -5. His lip mobility is perfectly within the range of normal. I said normal's 5 to 9, he's 7. Very normal lip mobility. So let's look at his face. Put our dots on, do our measurements. His profile is totally normal. His vertical facial development is totally normal. So we've got a class 1 molar occlusion. We've got unworn posterior teeth, normal facial development, but yet there's no overjet in the front to restore the teeth. The problem is in the front teeth somewhere. This isn't a jaw surgery case. His face is normal and his posterior occlusion is totally normal. Something's wrong with anterior tooth position. So here's the key photo. Andrew's line. Have him look off at the distance, drop the line from labella down. His centrals are right where they should be. His centrals aren't too far back. The second you see that photo and everything else is normal, you know the solution to the problem is not changing the maxillary anterior tooth position. It's lengthening it, but the overjet is going to come by moving the lower anterior teeth because the maxillary anterior teeth are right where they should be. Okay, there's the nice unworn teeth, except for the incisors. And he does have some erosion on just the lower first molars. He had quite a carbonated beverage habit when he was around 6, 7 years old. And so he ended up with the erosion on those lower molars. You know the erosion occurred during the day because the upper molars have none. So gravity keeps the carbonated beverage in the bottom of his mouth. And the erosion occurred before the second molars erupted and before the premolars erupted. That's why it's only on the first molars. His maxillary width is totally normal, canine width totally normal. So now let's do the treatment plan. Are we going to lengthen the teeth? We are. We know he doesn't show as much as we want, and we want to have a pleasing smile line. So that's an easy part of the treatment plan. We're going to move the incisal edge down until it's level with the canines and premolars. So that part's easy. Are we going to procline the teeth? No. The teeth are in the right place on Andrew's line. The teeth have a good inclination. We're not going to procline these teeth. Did these teeth erupt as they wore? Gingival margins are great ways to evaluate eruption. His gingival margins on the centrals, the laterals, and the canines look perfect. When somebody's anterior teeth wear and erupt, typically you see the central gingival margin coronal to the laterals and the lateral gingival margin coronal to the canines. So you see the gingiva code like this instead of what it's doing normally. Here's the problem. The upper teeth aren't the problem. The upper teeth need to be restored, but that's not the problem. The problem is the lower anteriors. Vince Kokich Sr. taught me years ago how he looked at cephalometrics. And what Vince always targeted was to put the labial surface of the lower anteriors, even with the bony chin or a millimeter in front of bony chin. Those lower anteriors are 3 millimeters in front of bony chin. So that's the problem. So treatment alternatives, are we going to procline uppers? Nope. Are we going to retract lowers? Yes. How much? Probably at least 2 millimeters to get them within a millimeter of bony chin. Are we going to intrude teeth because they erupted? Nope. What we're going to do is get those lower incisors back, which will create overjet, and then you'll be able to restore the 4 anterior teeth. Are we going to intrude the lower incisors? Nope. The gingival margins tell us the lower incisors are just fine. They're just too far forward. And nope, he doesn't need jaw surgery. He doesn't need his vertical dimension changed. And I would say because the maxillary arch is so well positioned in him, this is an airway neutral treatment plan. Us retracting a little bit to get overjet is not going to take away tongue space for him. His maxilla's got plenty of room for his tongue to live. Okay. How are we going to get the space? Vince Kokich is going to do interproximal stripping. So he's going to take a 0.5 millimeter thick disc, and he's going to disc each of these embrasures, taking a 1/4 millimeter off the mesial and distal of each tooth. 4 millimeters of space will let him retract 2 millimeters. So here it is. He's getting the teeth back in position. And there's my provisional restorations on the 4 incisors once the overjet was created. And there's the final case. Super simple case. You just got to get the tooth position corrected. Okay. And it's all about in those end-to-end relationships, it's all about overjet. It's getting overjet. All right, let's do another one that's a bit more severe, much older patient. So this person's interesting in that he actually does have class 3 molar relationship. His mesiobuccal cusp of his upper molar is between the first and second molar embrasures. And what happens when you have that relationship? You don't have any overjet. And when the anterior teeth erupt, they either erupt class 3 or they erupt end to end, but there's no overbite. And so you just do the same exact assessment on everybody. Take the facial photos, do the measurements. His profile is perfectly normal. His vertical development is perfectly normal. This is not a patient that you would typically think about orthognathic surgery. You would think about figuring out what's wrong with the overjet on his anterior teeth. Okay. So here's the strange part. As I said, he does have a class 3 molar relationship. Normally, when you see someone who's dentally class 3, not 100% of the time, but the bulk of the time, it's because their maxilla is deficient. So most class 3 cases treated surgically are treated with maxillary advancement. If this patient actually had, and I can tell you when we treated him, we didn't have all the awareness we do today about airway. But if you treated this patient, when you assessed him, if he went and did a sleep study and he did have airway issues, this patient probably would have got a maxillary advancement. But that's not what we looked at back when he was treated. So he's already missing one lower incisor. If he had that lower incisor, he probably would actually be almost a full anterior class 3. And here's the interesting thing. His posterior teeth are great. They have very little wear on them. Look how nice the upper premolars look. The wear is all on the incisors. So we're going to be talking about wear on these next few cases. And so we're going to talk about what we'll call pathway wear. Pathway wear is wear on the lingual of the maxillary anterior teeth, facial of the lower anterior teeth. Pathway wear is telling you the patient is locked in. They're restricted. They want more freedom. We're going to be talking about end-to-end wear, which is the patient we're looking at right now, where the wear facets are flat on the incisal edge. This patient that we're looking at, he doesn't have any pathway wear because his occlusions end-to-end. And then we'll talk a little bit about crossover wear. Crossover wear is where the mandible moves so far left, right, or forward that the lower incisors actually jump outside of the upper anteriors, and the wear facets go down the lingual of the lower incisors and up the facial of the upper incisors. So this patient has end-to-end, edge-to-edge wear. So because of his profile, even though he's class 3, we're not going to consider surgery when we treated him. But I would tell you again, if you put him through a sleep study and he had airway issues, today we would consider him as a potential surgical candidate. So if we'd have seen him when he was about 16 years old, he probably looked like that. And here's the problem. In order to get overbite, the orthodontist would have had to create overjet. And that could occur by taking the maxillary anteriors and proclining them. It also could occur by retracting the lower incisors. And so you would look at Andrew's line, you'd look at tooth inclination to make the decision, do you change the upper anterior position or do you retract the lower anterior position? Okay. So that's our goal right there. That's what we want his final occlusal relationship to look like. As I said, when he was 16, he probably looked about like that. What's happened is as he has worn those teeth, they do what teeth do. They erupt. And now he shows up at the office and he wants to look better. And the reality is, for you to get him to look better, you've got to change the tooth position. This isn't a vertical dimension problem. He has unworn posterior teeth. They fit well. The orthodontist has to either procline and intrude and retract, or you can use crown lengthening. We're going to talk about that, but it won't change the occlusal relationship. And so let's just do our treatment plan. It's the same. We're missing overjet. So we have the same options, always the same options. Are we going to lengthen his upper incisors? Yep. At rest right now, he doesn't show any tooth. And so we've got normal lip mobility. We're going to come in and we're going to lengthen the teeth about 1.5 millimeters. Now, to do that with no overjet, I would have to open his bite, which means I would have to restore a bunch of posterior teeth that don't need to be restored. Okay, so do we want to procline the uppers? Yeah, they're a bit retroclined. Do we want to retract the lowers? Yes. If we're not going to do jaw surgery, we're going to need to retract the lowers. Are we going to intrude the uppers? Yes. Even adding to the incisal edge, the teeth are still too short. And so we'd either do crown lengthening or intrusion, because we want to end up with a 75 to 85% width to length ratio, not 94 or 100. And so we move the gingiva relative to our new incisal edge position so that it gives us the width to length ratio we want. In this case, 80%. Are we going to intrude his lower incisors? Yes. They've really erupted. The gingival margins are telling you how much they've erupted. Okay. And no, we're not doing jaw surgery. We're not opening his bite. Back teeth are nice teeth. So could crown lengthening make the teeth longer? It can, but you still are going to have the edge-to-edge occlusal relationship. You'll still have to open vertical to restore the teeth to get them to look good. And so honestly, this patient doesn't want ortho, but when you tell them, well, the other option is we need to do surgery on your lower front teeth, your upper front teeth, and then I need to restore basically 17 teeth, suddenly ortho doesn't sound as bad. And so the treatment plan, Vince is going to remove one more lower incisor. And this one may be an airway unfavorable plan. That's going to leave him 2 lower incisors short. As I said, if that was the case today and there was the airway problem, yeah, we probably wouldn't have taken that tooth out. We probably would have advanced the maxilla. But there's the lower ortho setup. It's going to involve just 2 restorations. There is the upper ortho setup, 4 restorations. And what's the beauty of all that? Those restorations can be done in composite. He can phase into porcelain over time. So 6 total restorations. Here's following the intrusion. Brackets come off. We bond composite to make the teeth the size we want them to be. The brackets go back on. Here he is at the end of ortho. He's been wearing that composite now for about 9 months, so he's test driving the occlusion. He's done really well. Here was the composite. It was just 1 shade done quickly. It wasn't meant to be a permanent definitive restoration. And he went ahead and switched to porcelain. So there's veneers on the 4 upper incisors and veneers on the 2 lower incisors. But what looks like a really difficult patient to manage, in reality, is pretty straightforward. Now, the one thing about edge-to-edge patients I want to make clear is when you see somebody with edge-to-edge wear and you see all these notches and things, you are going to have to equilibrate their lower anterior teeth, because their lower anterior teeth are what created all those notches and wear patterns. So look at how he moves. He comes forward a little bit right. That catches that central. He goes to the right, he goes to the left. This is a dentist. He wants to be very conservative. So we're doing direct composite. So I've done the right central. I've got my incisal edge position where I want it. Now I've done all the anterior teeth with composite. Ask him to bite. His bite feels fine. Ask him to move where he likes to move. Boom, we have a problem. If I leave those occlusal contacts like that, he is going to break the composite off or wear it to look just like his original teeth did. We have to equilibrate the lower incisors. That also means we have to equilibrate that canine. Now, that's what he looked like when I was all done. Before and after. How well does composite hold up? That's pre-treatment, immediate post-treatment, 18 years post-treatment. Those photos were just taken this year. Same composites. And what I want you to notice is the incisal edges stayed level because we equilibrated the lower anterior teeth. So now when he grinds, he's not putting all those different notches and patterns in there. All right, deep overbites. Deep overbites with no tooth wear, typically it's always because of excess overjet. And again, it could be skeletal, could be arch length, could be tooth inclination. You just go through your analysis. Class 2 patients are notorious for ending up with deep overbites because they have too much overjet. So now when the anterior teeth erupt, boom, there's your deep overbite. So what do we do for these patients? Because ultimately the overjet is what ends up bringing in the deep overbite. You have 2 choices. If you simply realign the teeth, you're going to leave an open bite and the teeth aren't going to be stable. So the 2 choices are you either have to correct the tooth position and then retract maxillary anteriors, or correct tooth position and procline mandibular anteriors. Because you got to get occlusal contact or you're going to get the deep overbite back. So 23-year-old missing lower second premolars. So her lower arch is short. Her lower incisors literally occlude against her palate. There you can see on the Ceph where the lower incisors occlude. Her maxillary anterior tooth position is not bad at all. Tooth display at rest 2 millimeters. Teeth are a bit proclined, so they need to be brought back. Gingival levels are actually good. The upper arch just needs to be aligned a bit. Here's the problem. Look at bony chin. Look at where the lower incisors are. As I told you, the labial surface of bony chin, Vince usually wanted it 1 millimeter in front or even with bony chin. Why is it so far back? Because she's missing lower premolars. She's got a short lower arch. Effectively, she has that. And that resulted in the eruption of the lower incisors. What are we going to do? We're going to procline the lower anteriors and make room for second premolar implants. So we're just going to correct the short lower arch, right? So that distance right there is going to go away by moving the lower anterior teeth. There is the coil spring Vince is using to move those teeth. Space is opened. Simple case. And now you end up with a normal overbite overjet relationship. Now, in some cases, recession is a concern when you procline lower anteriors. So these days, sometimes we'll do surgically facilitated ortho and add bone before doing it. But generally speaking, if the arch is short because of missing teeth, typically the tissue, you can see this tissue is beautiful tissue. It didn't recede at all, even though those teeth were brought way forward. Okay, now let's move to the other really challenging one besides the end-to-end one, and that is deep overbites with pathway wear. So this gentleman's in his 60s, really significant wear on his anterior teeth, has almost zero wear on any posterior teeth. So this is not a vertical dimension problem. He's got class 1 molar relationship. He has a very minimal shift from centric relation into his intercuspal position. But look at where the lower incisors occlude, notched way up into those anterior teeth. And he's prepped the whole facial of the lower anteriors himself. So what needs to be evaluated? Same stuff. It's always the same stuff. So we put on our dots. He's got a relatively flat profile for someone who's got a normal class 1 occlusion, but we're certainly not going to consider jaw surgery for him because he's got nice posterior teeth, class 1 molar relationship, no wear on the back teeth. It's an anterior tooth position problem. Right, so there's our goal. That's what we're going to try and get to. Now, if we could see him when he was 16, he didn't look like that. If we saw him when he was 16, he probably had a very upright or retroclined maxillary anterior teeth, retroclined lower anterior teeth, deep overbite. A lot of people will live with that. He didn't. He wants freedom. And so he's just worn out his teeth. And they erupt. And now you get to this. And these are really tough cases because your brain wants to think, well, if I open the bite, I can make room to restore this case. Number one, he doesn't need his bite open. But number two, what you don't realize in a lot of these kinds of cases is when the lower incisors erupt so much, if you open the vertical to gain space, when you now restore the lower anteriors, they're sticking way up in the patient's smile. So as much as these patients hate to hear it, ortho is often the only solution for these cases because you got to procline that upper that's already been prepped on the palate. And then you have to intrude the lower so that you make room to put the teeth back where you want them. Right? So just go through the system. Upper incisal edge position doesn't show any. He's even with his upper lip. So we're going to want to lengthen the teeth stump. Not necessarily a lot. He's in his 60s, but millimeter and a half. So that will give you that tooth position. Then, are we going to want to procline the upper teeth? Wow, a mile. Look how retroclined those teeth are. There is no way you can restore those teeth into the correct position. There's just no way. Gingival levels, yep, they're going to be changed to get the correct width to length ratio relative to the new incisal edge. And his lower incisors, do they need to be retracted or proclined? They don't. Okay, they're definitely back a long ways, but they do need to be intruded. That's his resting lip position, his lower incisors, little tiny short worn lower incisors, he shows 5 millimeters of them at rest. If you build them up to be 10 millimeter lower incisors, you're going to be showing at 10 millimeter lower anteriors when he smiles and talks. It will look terrible. So treatment, yep. Procline the uppers, retract lowers, nope. Intrude uppers, yep. How much? Enough to give you a 75 to 85% width to length ratio. Okay, in this case, 77. Intrude lowers, yep, here's the key. His lower incisor gingival margins are currently equal to his posterior occlusal plane. That's how over-erupted these lower incisors are. Is literally the gingival margins match the occlusal plane of the posterior teeth. So if you built them up and then built the posterior teeth up, you can see how much the lower anteriors would show in a patient's smile. It would be terrible. And so the answer is the lower incisors, they need to be intruded or extracted because you're not going to be able to crown lengthen 5 millimeters on most lower incisors. So intrusion's a great solution, okay, but it's going to be a lot of intrusion. 5 millimeters is a lot of intrusion. So now, if you wanted to try and take them out and do implants, which is an alternative, take them out, do 2 implants, 4-unit implant supported FPD. If you did that, here's your challenge. The implants need to go there. The current bone is way up here. Whoever takes those teeth out and places the implants has to take away all of that bone so that the bone ends up down there. And this patient, I can tell you, didn't want to do orthodontics. But when you go through the alternatives and you say, well, if you do orthodontics, we can limit the number of teeth we have to treat to a really small number. If you don't do orthodontics, you're going to end up treating a lot of teeth. You're going to end up probably taking some teeth out. You might even have to take those upper centrals out, so you can put some implants in that are in the right position. So the treatment plan for him, no orthognathic, no increased vertical, and this is going to be an airway favorable plan. We're expanding the upper arch. Okay. So that's kind of the position of his maxillary central now. This is where we want it. And if you merge those two, and you imagine trying to actually prep that central so it would end up in the right position, you have no tooth left. There's no prep left. So ortho, intrude, and procline. Build up the lower anteriors with composite first so that they're a more normal size. Put on the brackets. And I'm showing you these cases because I want to show you the cases that Vince did. A lot of orthodontists today would be treating these same patients using aligner therapy. Aligners have some things that they can't do as well as fixed brackets, but aligner therapy does some amazing things today. So now you look at the before on the right and the after on the left. The composite has been built up. And now what you see is the built up incisal edges are now level with the occlusal plane of the posterior teeth. Before, the gingival margins were level with the posterior occlusal plane. And if you measured it, it actually is 5 millimeters of intrusion. A couple other things in cases like this, you'll notice when Vince finished, he did not put the anterior teeth in occlusion. He left about 1.5 millimeters of space. Since the patient had already worn away the palatal of the upper, I don't want to have to prep more. So what I want the orthodontist to do is leave me space so I can actually prep the tooth without prepping any of the worn area. So I don't have to take any more of the tooth structure away where the patient's wear was. So here he is before and after. How many restorations? 2 central crowns, 4 lower incisor veneers. Lower left canine was composite. 6 restorations and 1 composite. These cases look like they're full rehabs. In truth, most of the time, they're just anterior tooth position problems. All right, and I'm just going to show you this one as my pitch that you want to treat these people when you see the wear when they're young. Because composite can be replaced easily if they wear out the composite. You don't need to prep and put porcelain on these patients that have these kinds of wear patterns. The sooner you cover the wear with composite, the longer it will protect the patient's teeth. So, young patient in her 20s, she's got veneers that somebody did on her 4 incisors, got a ton of tooth display at rest, got a stepped occlusal plane because her anterior teeth have erupted. And her anterior teeth have erupted because she has pathway wear. You can see the angled facets on those lower anteriors. And you see the notches way up at the palate where those lower incisors are occluding. So in this case, it's going to be an ortho case again, but composite's going to be the final restoration other than replacing the 4 veneers. Lower anteriors are going to be done with composite. Palatal of the upper anterior is going to be done with composite. And so here she is. Now take a look at how the overbite and overjet has changed. The orthodontist has intruded the anterior teeth, maxillary anterior teeth. And now you got a nice level maxillary occlusal plane, nice level mandibular occlusal plane. And instead of doing full crowns, took off the porcelain veneers, I don't know how many of you know this, but if you happen to have a water laser in your office or hard tissue laser, you can take veneers off beautifully with a hard tissue laser. It just pops through. You just aim it right through there at the cement. It pops that cement, and they don't usually come off in one piece. Usually they come off in multiple chunks. But you don't have to take a burr to get the old veneer off. And so there's the new provisionals in place. And this is before the palatal was done with composite. And we're not doing full crowns just to try and conserve tooth structure. And the lower incisors are composite. And so we're going to make the palatal of the uppers composite. So there'll be composite against composite in terms of when the patient's in occlusion. And there's the final restorations. And now the composite's in place. And that's her final treatment. 4 veneers on the maxillary incisors, composites on the lower incisors, composites on the palatal. Okay. I'm going to actually do this one open bite case before we stop and do Q&A. It'll put me right where I was hoping to be because we haven't done an open bite case yet. So patient's 30 years old, 30, missing 4 incisors, has posterior wear because she's got a bunch of old provisional restorations. She's got an old RPD replacing the 4 incisors, class 3 molar relationship, doesn't have a big centric relation shift, but this is her occlusion. That's her biting. So there's her open bite, and there's her occlusion on the posterior teeth. So your options to close open bites: move lower anteriors up, lengthen upper anteriors, shorten upper posteriors, shorten lower posteriors. Those are your options. And so if I said to you, how would you manage this patient's open bite? The truth is you don't know, because you don't know which teeth are in the right spot and which are in the wrong spot, because you don't have the face yet. So that's what she looks like when she first came to me. I was the 8th dentist she'd seen in 18 months. And anytime a patient comes to me and says, you're like the 5th or 6th or 8th, whatever dentist I've seen, what it tells me is they actually value dentistry, but they don't like what they're hearing. Whatever these other dentists have told her, she doesn't like it. So I asked her, well, what did you hear from the other dentists? Every one of the previous 7 dentists wanted to extract all her teeth and go to implants. She's 30 years old. She doesn't want all her teeth extracted. So what are we going to do? We're going to do our treatment plan. What do we notice about her face? Really flat profile, actually class 3-ish profile. Vertically not bad, but deficient maxilla. Look at the over-eruption of the maxillary posterior segments. Look at all the gingival display in her maxillary posterior. Okay, there's the wear on the back teeth. She's worn right through a ton of old provisionals. She has terrible home care, which she admits she does because she hates her teeth. She's like given up. Her interpalatal molar width is actually quite normal. So 35. Her central incisor display at rest is quite normal, 3.5. Her lip mobility is quite normal, about 7.5. So what you realize when you do our treatment plan is her centrals are actually in a pretty nice place. Her laterals are in a pretty nice place. Her canines even aren't bad, at least the left side. What's bad is the posterior teeth, the maxillary posterior teeth. That doesn't look bad at all. But now let's draw in the posteriors. Okay. So there's her posterior teeth. Now we have big reverse smile line. Looks terrible. That posterior eruption is responsible for her open bite. And here's the problem. If you sent this patient's models to a laboratory for a diagnostic wax up, I virtually guarantee what would happen is the laboratory technician would lengthen the anterior teeth to match the posterior teeth, because that's typically their train of thought. If you don't have photographs, you're going to make the maxillary anterior teeth have the same plane of occlusion as the posteriors. In reality, what do we want to do? We want to intrude those posterior teeth. We want to bring them up. Right now, if you lengthen them, you have a 62% width to length ratio. Looks terrible. Now you have like 7 millimeters of tooth display at rest. What we want to do instead is we want to take those back teeth and put them up there. That's the correct treatment plan. And now you have a really pleasing smile. So now the question is, how do you get those teeth so the occlusal plane in the posterior matches those green lines? Ortho intrusion's one option. Crown lengthening, boy, those roots better be really long. Orthognathic surgery, or remove the teeth and replace them with implants. In her case, we have one other thing going on. She's skeletally class 3. So honestly, correcting this patient's occlusion, the easiest way to do it is correct the position of her maxilla. Okay, it's going to be an orthognathic case. And it's going to be really airway favorable because we're going to tip the posterior maxilla up and then move the maxilla forward into a class 1 relationship. Okay, just to give you a quick overview of how I did it, the diagnostic wax-up was done on models after they did the model surgery to simulate the orthognathic surgery. I then measured the length of the canine and first molars on the wax-up. I had composite shells milled by the lab. And then I prepped the upper arch. I relined the upper shell until, in fact, the canines matched the length that they did on the model on both sides, and the first molars from gingiva to mesobuccal cusp matched the length on the model. And then we did the lower, and I used a little silicone index to position the lowers made off the diagnostic wax up. And that's literally how she walked out of my office. She walked out of my office with a really big open bite. And for years I've joked, I can imagine if she went in some other dentist's office and said, I just saw Dr. Spear from my teeth. What do you think? Yeah, that's a little weird. 2 days after I did that, she had the orthognathic surgery. And now all of a sudden, everything fits. Got nice overbite overjet, got class 1 molar relationship. We did switch to implants in the maxillary anterior region. And she did need a lot of dentistry. She needed a lot of dentistry because of the condition of her teeth. The teeth just hadn't been maintained well. This patient is now 20 years post-treatment. She has had one area of little tiny decay on a lower first molar that was repaired. Other than that, she's had nothing, no problems of any kind over 20 years. Okay. But what I want you to realize is if you follow the treatment planning sequence, centrals first, laterals, canines, premolars, molars, gingival level, papilla level, and then look at overbite overjet relationships, these patients are very treatable patients. Now, granted, she was a full rehab, but if she didn't have such bad teeth, she wouldn't have been. She would have been treated without any restorations if she had really nice teeth. But what I hope you've gotten so far is that you've gotten the concept of how we look at patients very systematically. So what I'm going to do before Ali starts the Q&A section, I just want to share with you just a little bit about how I think about treatment planning in your practice and give you just a slight overview of how I think about the dentists we see at Spear Education. So this is our facility in Scottsdale, Arizona. And I think For me, it's important you know why spear education exists. Why do we do this? And I can tell you, I've been involved in education now 40 years. Graduated from dental school 44 years ago. Did a perio-pros program after dental school for 3 years. But for 40 years, what's really been important to me are a few things in terms of students coming. One is, I really believe every one of our faculty and our team wants to help dentists have more enjoyable days. I want dentists to have more fun on a daily basis, because I know dentistry can be really fun and rewarding. Sure, it's challenging. We all have days that it's not so much fun and not great, but it can be really wonderful. And so we want to help you see that. Number two, we want you to be more profitable. When dentists aren't profitable, they're stressed. And when you're stressed, you're not having fun. So we want to make sure what we teach you is applicable so that, in fact, you can take it home and you can apply it in a way that works profitably in your practice. We want you to have more time off. I hear some dentists that work unbelievable hours. And if you are really having a great time and you're doing things the way that we like to think works for most dentists, you're going to have more free time than you probably have now. And in truth, the way we reach those three goals is we help you become a better clinician. And that's what it comes down to. We help dentists grow clinically to provide the highest level of care that they aspire to, recognizing not every dentist has the same aspirations, which is awesome. But we have something for virtually everybody. So the bottom line comes down to this in terms of treatment planning in your practice. You only treat what you see. And pretty much you only see what you know, which is most likely what you've been taught. So just a simple example of that. Let me put this photograph up here. When most people look at it, they immediately see an old woman's face and an old man's face. It's really obvious. Now, if you look between their two faces, do you now see that gold chalice there? Because oftentimes people don't see that at first, but between their two faces is a gold chalice. Now, if we really dig into it and we look at the woman's face is actually a man holding a pot on his head. Her nose is his left elbow. Her chin is his left knee. Her lips are his waist and belt. We look at the old man, and it's a man playing a guitar. His face is the eye. The eyebrow is his hat. The nose is the right elbow. The chin is the right knee. And if you really keep looking, you'll notice that there's a woman standing in an archway for his ear. That's what treatment planning does. That's what the way we like to teach dentists does, is it allows you to see into a patient's mouth at a deeper level. And that deeper level, once you start to learn to see it that way, you don't unsee it. It doesn't disappear. And what happens is, as you become more competent, you grow in your confidence. And as you grow in your confidence, you suddenly start having different conversations with your patients. You suddenly start having different conversations with your team. And so I don't know the blend of all of you who are watching today. I can tell you, just to give you some feedback about, I'll just share two stories that were sent in to me. One from a study club leader who actually came to a facially generated treatment planning workshop. He brought 7 study club members. He's a very analytical guy. He primarily has an implant practice. He had tracked his referrals from his study club members for years as to how many they sent, how much money came from each of these referrals. The 12 months after they came with him to the study club, The referral volume from those 7 people was up 64%, which tells me they were doing 64% more implants. Okay. Another letter that came to me from a general practitioner from Boston. Frank, I took your seminar series for 10 years because I didn't feel I could afford to take a workshop. 2 years ago, I took the leap, started with facially generated treatment planning, then occlusion, then restorative design. Last year, my accountant wanted to know what was going on. My production from 2 years ago is up 100%. My accountant's new mantra is, you must continue to take Sphere workshops. So I'm here to just share with you, that's who we are as a company. That's what we like to help dentists do, is have more fun, be more profitable, enjoy dentistry, make you become a better clinician. Our goals have always been really simple. We want dentists to have more fun so that you want to go to work. We want you to be more productive. If you want more profitability, we want to help you become more profitable. So have more fun, be more profitable. And the way we get there is we help you grow as a clinician. So in a nutshell, that's really who Sphere Education is those 3 things. More fun, more profit, become a better clinician. As part of this with Course Karma, we're offering 25% off of our online membership, which includes all of our online, massive amount of online material that you can go to our website and interact with one of our people to help you walk through what's there. In addition, if you sign up while you're part of the Course Karma, we're offering 15% off of hands-on workshops. And if you're already a member of online, then we're offering 15% off of workshops. And with that, Ali, how would you like to do the Q&A? Do you want me to stop sharing my screen?
Hey, Dr. Spear, really incredible. Thank you so much for sharing that. You can keep sharing that screen if people want to scan the QR code. We also have the link in the comments there. We have some really great questions. I'm gonna get into it, but really thank you so much. That's been really incredible. Great feedback so far. And everyone, there is one more case that Dr. Spear is going to be sharing after the Q&A. So we are going to we're going to go over that as well too at the end. Is that right, Dr. Spear?
Yeah, I have one more Anterior open bite case that I'm going to share once we're done with Q&A. And I specifically put it at the end because it's there to show you what's possible today using aligner therapy and surgically facilitated orthodontics and some temporary anchorage devices as a way of treating some of these cases that actually would classically have been orthognathic cases. So the case I'm going to show you would classically have been treated as an orthognathic case, but it wasn't. It was treated using a lot of modern concepts that we have today. So we're going to do that right after the Q&A is over.
Okay, perfect. I'll get into the Q&A. So we had a question from Kevin and Victor. They were asking about does Vivos therapy work? And that's the ones that claim to expand the palate. Have you heard of that one?
Here's what I would tell you about expanding the palate. For sure, it is possible to expand the palate in children. The trick, and I'm not an expert on any of this. Rebecca Bachau, who's our resident faculty, she's an orthodontist. She has an outstanding presentation she does for us on the different methods of expanding a palate. The biggest issue with expanding palates is you need this. It works the best in a younger patient, and the ones that typically are the most effective are actually implant retrained right in the center of the palate. So they're actually expanding the palate itself. They're not trying to move the teeth to expand the palate. Mm-hmm. The risk of any expansion that actually pushes on the teeth is you can move the teeth right out of the buccal plate. And so the palatal expansion that's effective is the palatal expansion that goes into on each side of the midline suture of the palate, and then the screw is up in there and it pops the palate open. Can you do it in someone who's older? Yes, but in truth, once you start reaching adulthood, orthognathic surgery is probably just a much faster and cleaner way to do it, to be honest.
Yeah, that was what another question from Gagan. Can the maxilla be expanded at any age? So do you have a kind of an age threshold that you go by?
I think if Rebecca was sitting here, I believe she would tell you that up to, let's call it 12, using expanders, the kind I just mentioned, is pretty effective. As you start hitting 16, 20 and beyond, it gets much, much harder to pop the palate open, to pop the suture. So I think most of the time, like my grandson is now 10. And my grandson had his palate expanded significantly, but when she did it, he was only 6. And it just popped right open. And all of a sudden, next thing you know, he's got about a 5 millimeter diastema between his centrals, because the whole palate's just opening up, which is kind of crazy when you see it happen, especially in your grandson. You're like, oh. I don't think you get that kind of expansion as you reach that ages of, like I said, 14, 16, 20. For sure, surgical expansion can be done virtually at any age, orthognathodically.
Okay. I think that answers the questions for sure. There was also some comments about recent studies that show ortho doesn't impact obstructive sleep apnea. What are your thoughts on that? Is that true, or?
There's a great debate between the orthodontic world and a lot of other people. The Orthodontic Association in the US came out with the ortho position paper a few years ago that basically said there wasn't any evidence that ortho has a negative impact on sleep. And then you have other people that say, no, actually, if you've had your premolars taken out and you've had everything retracted, you should actually go see an orthodontist who specializes in re-expanding. You should open spaces for your premolars and you should do all those things. I think Mike Gunson, who's a phenomenal oral surgeon, part of our resident faculty. Mike practices in Santa Barbara, does nothing but orthognathic surgery, does deal with a lot of airway patients. And his answer is, in some patients, orthodontic retraction might be a problem, and in other patients, it's not a problem at all. It's not a is it bad or is it good? It's some patients, it might have a negative impact. Some patients, it probably doesn't have any impact. But you can't like just take a brush and paint over every patient and say, well, if we do ortho and we take out premolars, we're gonna create a sleep problem for you. It's not that clear cut, I guess would be my answer.
Okay. Nuanced, yes.
Yeah.
So Joseph was asking, what is taught in Spear Online?
Say that again, I didn't hear.
What is taught in Spear Online?
Oh, it's massive. It's so all of the treatment planning for all of the different categories, the aesthetics, the function, the structure, the biology, all of prepping veneers, prepping inlays, prepping onlays, prepping full crowns, all of the bonding stuff, how to make provisionals, huge curriculum on implants, implant provisionals, huge curriculum on fully edentulous implant cases, and also on dentures. Practice management. There's a ton of practice management stuff on our online site. And there's a ton of team building stuff on our online site. So you have the ability to pick a curriculum and actually suggest that your team take these, let's call it 3 classes if you're a dental assistant, or 5 classes if you're a dental assistant. And then at the end of each class, they have to take a quiz, and then they can show, the dentist can look to see, did they actually take the class? Did they complete the quiz? So it's a math. I mean, we started it in 2009, so 14 years ago. I can't honestly tell you right now the total number of courses on there. I know I have about 250 courses on there. So you feel free to go on and browse the curriculums that you'll see on the Spear Education website, and get in touch with one of our advisors from a link in the chat, and they can walk you through a demo of the whole thing. I think you'd find that and we've got endo stuff, ortho stuff, obviously the restorative stuff. It's a massive library. It really is.
Yeah, I had Spear Online as well, and it takes a lot. I like the pathways as well, so it kind of helps organize which direction
Yeah,
you want to.
going to a curriculum-based process where you can say, well, I want to learn about this, and then here's like 6 courses to walk you through that, is way more effective than you just trying to go in and find courses. You really do need the pathways to utilize it the best.
That was the most helpful for me. So we have a question from Sadia. What software do you use to measure angles, etc., on facial photos?
You know, I do all of it with Keynote in a Mac, but that's just because I'm really comfortable with Keynote in a Mac. You can do it as well in PowerPoint, but there's other ways to do it. If you just have the photo, if you just take a photo on your computer, you actually can download digital protractors from different sites. If you just look up digital protractor, like Google it, you'll discover that there's a whole bunch of little digital protractors, and you can actually take a photo of your patient. Don't even put it in Keynote or PowerPoint or anything. Just put it up on the screen, take the digital protractor, move it over, and it will give you all the angulations that I was just talking about. It's amazingly simple to do it with the digital protractors.
Yeah, I've seen you're been able to do with Keynote. A lot of people appreciate that too, because you also have the frame of the teeth that you move and stretch.
Yeah, so the concept of templates is something we've done for a really long time. So we have the templates where the tooth drawings are already done, they're pre-drawn. And so all of the little images of teeth that you see, I'm not drawing those on each patient. I'm just going to one template that's got them all sitting there, and I copy them, and then I go to my photograph and I paste them, and then I just drag them to fit the size I want. I can draw 6 anterior teeth in about a minute and a half. It's super easy. We actually do all of that is on Spear Online as well. So how to do that in Keynote or PowerPoint, how to take the drawings, copy and paste them. Yeah, all of that stuff. There's videos, lessons on all of it.
I remember seeing that in when I took the seminar, Art of Treatment Planning case selection. So we have a question from Cynthia. She was asking, can you explain what you mean by equilibrate the mandibular teeth for cases with edge to edge with notches? So I believe this is the one where you're kind of evening the bite. What did you mean by equilibrate the mandibular teeth?
Yeah. I might just drop out of this and show you something real quick that might make it more understandable.
Let's do that.
Am I still sharing? I am, aren't I?
I'm not
there we go. Okay. Okay, hold on.
And then after this, we will maybe take one more question and then go into the last case that you wanted to share.
Yeah. So I'm gonna share my screen again. Okay. So I'll just quickly walk through. So you see all the irregular edges in this young guy? He's in his 20s. Every one of those irregular wear patterns lines up with the position of a lower incisor. Every one of them. And so he wants his upper anteriors treated. And we're going to do it really conservatively with direct composite, but we're going to end up with nice, smooth, pretty incisal edges. You are now going to have to go in and adjust those lower incisal edges so that they're perfectly broad and flat contacts. So let me get you to what that looks like. So we do a diagnostic wax up. Here we go. So we figure out where we want. There's the diagnostic wax up. So that's the tooth position I want. Now what I do is I move him into a protrusive end-to-end position, a left position, a right position. You'll notice when I move him protrusive, I'm using articulating ribbon. He's only touching that lower right central incisor. That is going to wear my composite away to have the same notch that his own tooth had there. So we need to adjust, equilibrate with a burr that lower anterior. Now I'm going to do it with a cleoid discoid on the model, but I'm going to scrape it until now when he goes into protrusive position, now the lower anteriors are touching all the way across both central incisors. Smooth, broad contacts. And then we do the same thing when we go left. When he's on the canine edge to edge, I want him touching the centrals. If he's not, then I need to adjust the canine to make sure he's on those centrals. So when we say equilibrate, what we're saying is we're adjusting the length of the lower incisors to make them have really broad, smooth contacts. And then I'll just jump to the end of this. And so then what happens is after you treat him, so here is the composites done. Now you do the exact same thing in his mouth where you have him come forward with that articulating ribbon, and now you adjust the lower incisor with a burr so you get those same kind of big, broad contacts. So that's what the equilibration process is. But if you don't equilibrate a patient with edge-to-edge wear like this, your composites, potentially your porcelain, are going to look just like his teeth. You have to do the lower equilibration. Okay. Well, I just lost you.
Sorry, I was on mute.
Oh, okay.
We did have one question about the seminar, like what's the difference between that and this class? You know, obviously that's much longer, but what would be taught during the art treatment panel?
So we spend a lot more time on all of the things like tooth position, gingival levels, crown lengthening versus intrusion, moving papilla heights, using surgery to apically position papilla, using ortho to either apically or coronally position papilla. It's just take what I went through and imagine taking each segment of it and making it a much, much bigger deep dive into it. That's what plus the case acceptance stuff, the case presentation stuff.
Okay, perfect. We're 9:45. Should we go on to that last case? We do have a ton of other questions that I'll try to answer after with the emails, but do you want to go into the last case that you had there? Or do you want me to ask more questions? We're at for you would be 6:45.
Yeah.
With the
go ahead and do one more question, and then
all right.
I'll jump in.
Okay, let's see. So we had Z was asking a couple questions about is there a minimal tooth structure requirement for composite buildup or a maximum limit of the height of composite buildup? He also asked, a lot of this I'm sure just depends case by case, but can we restore severe wear cases with composite?
Yeah, absolutely. Composite is like your best friend on severe wear cases. Modern composites, the modern nanofilled composites are so wear resistant and so strong. The beauty about a wear case is it's worn because it's natural tooth structure. If you had a bunch of crowns there, you couldn't bond to it, but the teeth wouldn't wear either. So when you have a ton of tooth wear, it means you have a ton of unrestored tooth structure that you can bond to. And so we teach an entire class on how to phase patients with severe tooth wear by either using composite or milled composite from the lab or from your own milling machine. And I would routinely tell you that I would expect composite in a patient with wear to last 8 to 12 years wouldn't surprise me at all. I mean, they just hold up incredibly well. And if they do anything, it's just that they wear some. Well, no big deal. You just go ahead and redo it at 8 years. And you're right back where you started. So yeah, composite has totally, as composite technology has improved, it's just totally changed the way we think about restoring really complex wear cases. Because now, once you get it set up with composite, you can say to the patient, well, in 5 years, if you want, we can now do your front teeth with porcelain if you want.
Mm-hmm.
Or we could redo the composite somewhere down the road. But it just opens up a mass window for you to be able to treat patients that you otherwise wouldn't be able to treat.
Okay, all right, that's a great point with that. Okay, so do you want to go on to the last point?
I probably should if we're gonna get done relatively close to on time.
Okay, okay, I'm gonna stop my video here and I'll jump back on.
Okay, am I back up on there? Yep.
Yeah.
All right. So, strangely enough, today it seems like I've shown you a lot of dentists. This is also a dentist from Montana, and she's 38 years old, and that's her bite. She's in occlusion right now. So her chief concern is appearance and the open bite. She has a history. The left lateral was lost traumatically when she was younger. And now there's an implant in the left lateral position, and the left canine is ankylosed. So left lateral implant, left canine ankylosed. When she was 24 years old, she had ortho, and you can see how big the open bite is. I mean, it's there. So typically when you think about open bites, you kind of think about intrusion, surgery, expansion. Those would be options. Lisa came to me to see if I had a restorative solution for her. Now, here's the problem. She doesn't have any restorations other than that lateral implant and a crown on the canine. Otherwise, she doesn't have any restorations. She does have the pre-ortho, the old ortho records. And what I want you to look at is in 2005, here's her photographs pre-ortho, and she is almost full class 2. Look at the amount of overjet she has. Now, look at 2006, 1 year later, and suddenly she's class 1. And now she has anterior contact. Well, if you think about it, how in the world did she go from having like 5 millimeters of overjet to having anterior contact? And most likely what happened is the orthodontist treated her by moving the mandible forward and then attempting to get all the teeth to fit with the mandible in an anterior position. And it worked. It looks nice. The open bite's gone. Everything seems fine. Okay. So there was the pre-ortho. She hadn't had the implant yet at that time, but she had lost the tooth. Here she is in 2010. And in 2010, she's getting a little bit of an open bite. So this is about 4 years post-ortho, 5 years post-ortho. But remember, she's a dentist and she's aware that she's been clenching frequently and had significant pain, and she made herself an NTI, anterior appliance. And the pain went away. But she developed the open bite. And so this is when I met Lisa. It was 2014. And my exam revealed nothing abnormal about her jaw joints. And when you think about open bites, I want you to realize one of the most common things that produces an anterior open bite is degenerative joint disease. When somebody's condyles start degenerating from arthritis, the mandible will go back and up and they'll develop an anterior open bite. Now, she developed an anterior open bite secondary to wearing the NTI. And any anterior appliance has the potential to end up developing an anterior open bite if the patient wears it too much, or if when they're wearing the appliance, it now allows the condyles to seat. Because as the condyles seat, now you're going to get the anterior open bite. So what I would tell you is, if you have a patient that develops an anterior open bite, one of the first things you want to do is get upper and lower models. Today, you might just scan and print them. You could do old-fashioned analog way and make stone models, but you want to get a set of models. And first thing you want to do is take those models and hand articulate them. And if when you hand articulate models, the occlusion looks good, but in the patient's mouth, there's an anterior open bite, it is highly likely it's related to the temporomandibular joints, and that, in fact, the mandible's dropping back. If you had somebody wearing an NTI or an anterior bite plane, and they develop an anterior open bite, now, when you hand articulate the models, if the models don't fit, if when you hand articulate them, there actually is an anterior open bite, now you know, in fact, the tooth position has changed. It's not the joint that's changed, it's the actual tooth position that's changed. Okay. So she came in asking if I could come up with a restorative solution. And so I mounted models, and one of the tricks I've done for years is when I mount the models, I make each tooth separated. I take a saw and cut them, and I use a dowel pin so you can take teeth out. It's a very fast way of looking at, well, if I was to restore her back teeth, could I actually shorten them enough to get her front teeth together? So here I've taken the upper second molar out, closed a little bit. Here I've taken the first molars out on both sides, still got a big open bite. Second premolars out on both sides, still got a big open bite. First premolars out, there's no way I'm going to be able to help her restoratively. There's just no way. I would destroy her teeth, and the teeth don't even need restorations. And so restorative, no, not going to be an option. But we can treatment plan her. So let's go right back to facially generated treatment plan. Let's figure out where the teeth should be. So we do our facial analysis. Mid face, lower face, boom, right on. We do our profile. Glabella, subnasale, pagonian, measure our angles, totally normal. Her skeletal development is totally normal. Her Andrews line, totally right where you want it. Her centrals are right on that line. So the good news is her facial development is totally normal, but her tooth position is terrible in the maxillary arch. The mandibular occlusal plane is terrific. Nice and level. So now we go to our lip at rest picture, and wow, that left central looks pretty nice. We go to our lip mobility, normal. And suddenly you realize, here's kind of the treatment plan. Take that lower occlusal plane, lift it up to the left central, and now everything you see that's hanging below that green line has to go up. Now, the other thing you have is you have two teeth, well, an implant and an ankylosed canine. The good news is they're in a good position because you can't move them anyway. And so if you had to try, if those teeth weren't in a good position, this would be a really big problem. So here is Lisa's treatment plan. That's where everything is. And when it's done, it needs to look like that. Now, I'm not the orthodontist. She's already seen 2 oral surgeons. She does not want orthognathic surgery. But today we do have some tricks up our sleeve that we didn't have years ago. And one of them is surgically facilitated orthodontics. Some people know it as Wilcodontics, where you basically wound the bone and graft the bone, and it allows the teeth to move faster. And you also have temporary anchorage devices that you can use to help intrude teeth. And so what did I do? I actually sent her to Fayetteville, Arkansas, to a good friend of mine, Rick Robley. He works with a periodontist, Mike Curry, and they're going to do surgically facilitated orthodontics and aligner therapy to treat Lisa. So there's wounding the bone on the left. There's the graft particles on the right. You can see there's a temporary anchorage device that's been placed on the left-hand picture way back between the molars, on the right picture just between the canine and lateral. This is what the maxilla looks like after the surgery. You also put a temporary anchorage device in the palate. And then on the mandible, 2 more on both sides. And then the whole thing is done with aligners. I think she had 34 different trays. And because you're using temporary anchorage devices, now if you notice the elastics, he's actually dragging the whole mandibular, all the mandibular teeth in an anterior direction, basically proclining them. And he's intruding maxillary posterior teeth. And this is how Lisa turned out. So pre-ortho on the left, post-treatment on the right. Pre-treatment on the right, post-treatment on the left. And of course, she has to wear retainers because there is a risk of everything relapsing otherwise. But there's Lisa's before and after. So as I said in the beginning, I just want to say thank you to Ali and thank you, Course Karma, for putting this on and helping all of us at Spear Education. I want to say thank you to all of you that are in attendance. I know for probably a bunch of you, it's getting pretty late on the East Coast. I'm at my home just north of Seattle, so it's not so bad here. But I really appreciate the opportunity to share. And I hope we get to see you in Scottsdale or on Spear Online.
Thank you so much, Dr. Spear. That was really incredible. Thanks for taking your evening to be with us today. We're getting just a lot of thank yous, a lot of people who are still stayed to the very end of this room, but truly wonderful presentation. I really
Thank
appreciate
you,
it.
Ali. Thank you very much. And everybody have a good rest of the week and a good weekend. So thanks, everybody.
Thanks, everyone. Thanks, everyone, for joining. Thank you. Bye, everyone.
Bye-bye.
Thanks, Dr. Spear. We'll see you next time.